So we move now to the prestigious Neufeld lecture that will be delivered by our good friend, Professor Jeroen J. Professor Bax is Professor of Cardiology and the Director of Non-Invasive Imaging Center at Leiden University Medical Center at the Netherlands. He is also the President-elect of the European Society of Cardiology. Prior to his current position in the ESC, he was the Chair of the Congress Program Committee and the Chair of the Committee for Practice Guidelines. Professor Bax's main interest is in the application of various imaging modalities in clinical cardiology. It is a real honor and pleasure for me to invite Professor Bax to deliver his lecture, Cardiovascular Imaging for Risk Stratification in Sudden Cardiac Death. Please, Professor Bax.
Thank you very much, Dr. Rosenman, Dr. Segev, Dr. Bilotonik. It is a pleasure and an honor to be here. It's a big honor to may deliver this lecture to you, especially in the presence of the daughter of Dr. Neufeld. So I'm happy to be here also on behalf of the European Society, and I would like to express also, following Professor Pinto, our thanks for your friendship and your support. I was entitled this lecture, Sudden Cardiac Death, Multimodality Imaging to Assess the Arrhythmogenic Substrate. If we look at sudden cardiac arrest statistics, as shown here, we see that one of the most common causes of death in our developed countries is sudden death. And this was already highlighted by Dr. Antman, what he showed on the brochure. There is also a high recurrence rate, and there is also a very poor survival. This is one of the things that we're dealing as clinical cardiologists with all the time, and is a very difficult situation. If we look at another aspect, less than 5% of the patients will survive such an episode of sudden cardiac death, and therefore the focus has really shifted towards prevention. Prevention is the key word in sudden cardiac death. So trials have been developed to look at prevention of this phenomenon. And after medical therapy, the ICD was introduced, and it was shown that all these different trials shown here showed a very clear reduction in mortality. All of the trials showed a reduction in overall death, and all of the trials showed a huge reduction in arrhythmic death. This is something that has really increased the power of cardiology. But this also has another side of the coin. And if we're thinking about the area of cost containment, this is what I got from Sea Nissam, who was working by then at Boston Scientific. And you see here the increase of the annual ICD implantation per million of inhabitants in Europe and the US. And you see that over the years there is a huge increase in actually the number of devices being implanted. In our center, which is a middle-sized center in the Netherlands, I would say 400 to 500 ICDs are being implanted every year. This is something that eventually the society cannot keep on doing. And you see at this moment in time that there is already a little bit thinking about how do we continue on this track. What we have done in our place is that we have most of the patients organized in care tracks. And from that, of these registries, these care tracks, we can look at certain insights of the diseases. We started that when I attended I think it was the opening lecture at the HA in 1999, if I'm correct, by Bob Bono, who presented this concept of Get With the Guidelines, which I saw back in Dr. Antman's slides also. Based on that, we started all these care tracks, we started these registries, and it's taken from the clinical presentations that we have. So here I show you, this is already a bit older, from 2004, but it shows you what the patient presented with, that presented to our center with sudden cardiac death. So underlying etiology, this is more than 400 patients, 400 consecutive patients, and what is very clear is that coronary artery disease is the #1 underlying the sudden death presentation. So these patients were resuscitated, went for an extensive diagnostic track, and based on that, we determined what was the cause of their presentation with sudden death. We see also other causes such as dilated cardiomyopathy, ARVC, hypertrophic cardiomyopathy, congenital disease, and I've also pointed out there at the bottom the ejection fraction, so the mean ejection fraction, and that is an important thing of these patients surviving a sudden death, is 45 plus or minus 22%. And so on the one hand, we're speaking about this increase in ICDs in the patients with a low ejection fraction, because that is what we see. But on the other hand, we see this number here, which is a relatively high ejection fraction. So I'm calling your attention to 2 points. One, we need to think about, does everybody need an ICD below 30%, as it's currently the guideline? But at the same time, we need to think about patients with a higher ejection fraction, how we have to go on in these patients. Do they need an ICD sometimes also? Of course, this is very difficult, and I'm going to show you some evidence that has been gathered that there are ways to specifically look at certain features of these patients. It's all observational work. There is no real prospective things, but I'll show you what we have. The guidelines then moved on, and the guidelines is recommendations, and the Class 1 recommendations are a must-do recommendation. So HA, ACC, HRS, and ESC guidelines are all on the same track, pointing out that for primary prevention, ICD implantation in chronic CAD has the following features. If you have had an ACS or an infarction, one should probably wait a little bit and reassess the ejection fraction, and based on that, make the decision for an ICD. After revascularization, one should also wait because ejection fraction may still increase, and then the need for ICD would be less. The main driver is actually an ejection fraction, LVEF, of less than 30 or maybe to 40%. And this is a difficult thing, because ejection fraction is not a solid state phenomenon. If you, and that shows already these 2 lines there, if you have had a recent ACS or if you've had a revascularization, the ejection fraction may increase. And then all of a sudden you would no longer need the ICD. So there are a lot of questions that can go through your mind by this definition of just looking at an ejection fraction. And we should also take into account that ejection fraction is only the difference between the volume that's in and the volume that goes out at every beat. And recently, my attention was drawn to that again when I look at the patients with severe mitral regurgitation. And we discuss in the heart team, as was also indicated this morning, we discuss in the heart team, does this patient need an intervention, severe mitral regurgitation? And the first question that comes from somebody, what is the ejection fraction? And so the ejection fraction is our idea of the performance of the left ventricle, the power of the muscle. But it's not completely that, because if you look at this patient with the severe mitral regurgitation, at this image, you see a heart that's moving like so. But still this ejection fraction is 40%. And that is because half of the volume goes in the left atrium and half of the volume goes forward through the aorta. So the point about just going by ejection fraction may not always be the ideal way forward. What is then better? There is no alternative at the moment, so we stick to this guideline. But I'll show you a little bit some ups and downs. Let's take a look at our Leiden registry based on MADIT2 criteria. So this is 250 patients that I showed to you, all coronary artery disease, 92% with a previous infarction, presentation, VF 60%, VT 40%, and again this relatively high ejection fraction of 39%. All of them were treated according to guidelines with an ICD, and the follow-up duration that we presented here was 3.8 years. And I point out to you this important bar graph where you see actually that 61% over the 3.8 years never had a shock on the ICD, whereas 39% of them had a shock. So this is a difficult situation, because we could say, yeah, but next year they will have a shock, so they needed the ICD. And on the other hand, we could say, what amount of money are we spending according to this Class 1 recommendation to implant ICDs in all of these patients? I take then to you the MADIT2 trial itself. This is all the patients going into the MADIT2 trial, and you see the same phenomenon. Here you see the 720 patients, and you see no shocks in red, 65%. and appropriate ICD shocks, and we did not even discuss about appropriate and inappropriate ICD shocks, 35%. So don't get my point wrong. I'm not an antagonist of an ICD because I fully believe in this therapy. But in the era of cost containment, but also in a scientific era where we try to understand what causes a certain disease or a certain phenomenon, there are probably ways in the future to do better. The future is not going to be tomorrow, but eventually I think we can make some progress in this. So if we look at our database, we looked at what is the pathophysiological substrate for the sudden death in coronary artery disease. Is it depressed ejection fraction representing mostly scar tissue? Is it the previous MI representing mostly scar tissue? Is it ischemia, which is a different phenomenon than just a scar? Is it ischemia? And I would like to put that under hibernating or stunning or ischemic on exercise. I would like to call that as jeopardized myocardium. Or is it dysfunctional but viable tissue, which I also put in the category of jeopardized myocardium? So we looked at our database. 200 of these patients with coronary artery disease and ICD treatment had a gated SPECT study. The mean ejection fraction was 34 plus or minus 12%. And we evaluated on this simple scan the extent of scar tissue, ischemia, and viability with a 3-year follow-up. The endpoints that we used were cardiac death, heart failure deaths, recurrences, ATP, and appropriate shocks. ATP is another topic that we can discuss about. Is that really a good endpoint, anti-tachycardia pacing? Also, that discussion has not been closed. Let's just look at what we have found. We found in yellow that if there was jeopardized myocardium that was not revascularized, because this, and I forget to say that these patients that come to our hospital with an aborted sudden death, they get an angiogram, they get an echo, they get all this systematic workup. In addition to that, based on the findings that we have, including the ischemia and viability assessment, the patient are referred for revascularization or not, and after that the discussion takes place about ICD. Jeopardized, not revascularized myocardium was a strong predictor of the events, as we would have expected. A large scar in yellow was also a strong predictor of these events. The bigger the scar is, the more the likelihood is that you get an event. And of course, the ejection fraction, and again in yellow, 59%, also reflects the extent of scar tissue. So we found these different phenomena that were related to these patients presenting with an aborted sudden death. The field is moving, and I think one of the interesting things in nuclear cardiology is the assessment of sympathetic innervation. This is not new. This was done by Doug Zipes many, many years ago, and he worked specifically on this topic of sympathetic innervation and sudden death. And one of the tracers that you can use is MIBG, which visualizes cardiac innervation and also cardiac denervation. It behaves as norepinephrine, and the tracer is internalized by presynaptic nerve endings. This is a slide that I borrowed from Marcus Schweiger from Munich, and it shows directly to you how in red the MIBG is injected in the blood, then taken up in the sympathetic nerve terminals, and it gives us a marker to visualize how much sympathetic innervation or denervation there is in the heart. Here you see planar images, and the planar images are not the nicest to look at because nowadays we're used to see everything in 3 dimensions, but these planar images give us a message. It's a very simple message. You see a region of interest on the left side, and you see a region of interest in the right side, and it's that circular region of interest that we see here in the middle that gives us an idea of how much MIBG is taken up in the heart. We see a patient with an ejection fraction of 33%, and we see that this ratio between the square box and the circle, which is the mediastinum, where we should not see anything, and the circle is the heart, gives us the heart to mediastinum ratio. If that is relatively high, there is a lot of innervation in this heart, as you see on the panel of the patients with an EF of 33%. If that is very low, as you see on the other panel with the patients of an ejection fraction of 21%, there is not much innervation left. We can also do SPECT imaging of this MIBG, and here you see the SPECT images of a patient which had a severe denervated area in the inferior wall and in the septal wall. This was then published by Marcus Schweiger's group, and they showed that in a setting of acute infarctions, that the extent of cardiac sympathetic denervation is far more extensive than the infarct size. What you see here is on the left panel, the technetium sestamibi infarct size in red. You see it's relatively small. And then you see in the same patient an MIBG innervation study where in blue the area of denervation is shown. So there is a big mismatch between the scar extent and the denervated area. And that creates the concept that around the infarct core there is this mixture going from pure scar to normal tissue. And it is this border zone that people have become interested in and feel is also related to triggers for sudden death. This is one other study from Marcus Schweiger's lab, and you see this mismatch size, so the size of the infarct size versus the denervated area. And you see here that that relates with markers of repolarization abnormalities, the QTC. You see that it also correlates with depolarization abnormalities on the signal average ECG. The bigger this mismatch area is, the more electrical instability was noted. So then the question that is, will this innervation imaging allow further risk stratification? Can it predict arrhythmias? Can it predict sudden death? And for that reason, we have looked at our patients to assess the predictive value of cardiac sympathetic nerve dysfunction assessed with MIBG in ICD patients. So this patient had an ICD for sudden cardiac death and cardiac mortality. So the study population is 116 patients. 116 patients referred for ICD implantation based on guidelines for primary prevention. Here you see the characteristics. You see an ejection fraction of 27%, ischemic cardiomyopathy based in most of the patients. The primary endpoint with appropriate ICD therapy was seen in 24, and the secondary endpoint, which is the composite of appropriate ICD and cardiac death, was seen in 32. These are the images of these SPECT images. And you see here the resting perfusion image on the left, where there is very global perfusion. There is not any big defect, just a little bit in the center, which is a small apical defect. But then you look on the right panel, and you see all that purple is a defect. So there is a huge area of denervation. This patient had an EF of 28% and received several appropriate ICD shocks. When we looked at the differences between a big MIBG defect and a small MIBG defect, so a lot of denervation or very little denervation, we saw that the ones with a lot of denervation actually had the highest event rates of ICD therapy, indicating that this denervation is a marker or is a trigger that we can look for to maybe better predict who needs an ICD and who doesn't. And it's actually at this moment in time that in the United States, in combination with centers in Europe, there is a big trial being prepared with this MIBG tracer to see if this can help in the prediction of ICD need. Not only nuclear imaging worked in the field of looking at this border zone, it was also MRI that immediately picked up on this. And this slide I particularly like. It comes from Dr. Stevenson in Harvard, and it shows very clearly that we should think about what is the pathophysiological substrate for sudden death in coronary artery disease. You see in the middle the big scar, which is of course a trigger for ventricular tachycardias. But you see also that the focus is on this area around the scar, this border zone. That is the area where the instability is. My idea is, but there is no definitive proof on that probably the central core is related to the monomorphic VTs, whereas the area around it is probably related to the polymorphic VTs. But both of them are benefiting from treatment. CMR, to assess arrhythmic substrates, is actually providing LV volumes, LV ejection fraction, what we need, but also they use this late gadolinium enhancement, which triggers only the scar. And the scar is colored in white, as you see on the bottom left. So the scar area is the target. This is the first study that was published, coming, I think, from Dan Berman's lab by Dr. Di Bello, 48 patients with coronary artery disease, and they did this MRI just looking only at the core infarct tissue. They did an EP study to assess VT inducibility. They saw that 21 patients were not inducible, 18 had a monomorphic VT, and 9 had a polymorphic VT. The results showed this. Ejection fraction, either non-induced, monomorphic, or polymorphic, was the same. But the infarct size was a strong predictor of the monomorphic VTs. And that fits with the hypothesis. The infarct size goes with the monomorphic VTs reflecting the scar tissue. But then again, you can go one step further, and this is the work from Hans Reiber, who has been running successfully in Rotterdam and in Leiden in the Netherlands image analysis core labs. And they have developed the concept that with MRI you can also assess the transition between the pure scar and the normal tissue. So again, this border zone, and you see that here colored in yellow. Based on signal intensities, you can try to tease out the difference between the pure scar and the border zone. So this comes from our center. We took 91 patients that were referred for ICD based on MEDI2 criteria with coronary artery disease. The MRI was done for volumes, ejection fraction, looking at scar tissue, infarct core, and also looking at peri-infarct zone, this border zone again. And the primary endpoint was the shocks on the ICD. This I showed to you already. First thing, what we confirmed from the Di Bello study is that the ejection fraction was not really different between the patients with and without ICD shocks. If you look here at this slide, you see that the total infarct size was predictive for shocks on the ICD. However, if you discriminate in this small group, the infarct core did not contribute so much, whereas the peri-infarct zone contributed more. In my opinion, it will probably be the combination between the extent of scar in the center and the extent of border zone around that, what's going to drive it. If we tease out then this border zone and you express it purely quantitative, it's called here infarct gray zone, and because of the median, they've taken a cutoff of 16.7 grams. You see that the one with very little border zone have very little shocks, whereas the one with a lot of border zone, they have a lot of shocks. The last couple of slides that I'd like to show to you is nuclear cardiology is going in the direction of direct visualization of denervation. MRI is working more on the field of infarct, core, and the tissue around it, but echo can also do something. And if echo can do something, that would be a big step forward, because echo is a technique without radiation that can be used as many times as you want. And with echo, we can look at strain. And strain is probably the next step after ejection fraction. Strain looks at the active deformation of the myocardium. So this is really looking at the force and the power of the myocardium. And you see here different views. This is the 2-chamber, the 3-chamber, and the 4 or 5-chamber. And these are merged into a polar map on the right bottom. And the polar map gives us an idea of the global strain, the global performance of this ventricle. And you see there on the bottom right that the global strain in the entire heart is -20. So -20 is a normal value. Minus is only because we're looking at the longitudinal strain, which is the up and down deformation. So forget about the minus, just focus on the 20. And if you develop scar, you're going in the direction of 10 and even 5. So what we did is that we have validated the extent and the severity of the reduction of strain versus contrast-enhanced MRI, as you see here. So the blue in the middle is a patient with an infarction, where you see that there is, in blue, very little strain, and that correlates with the area on the MRI to the lateral wall. So segmental longitudinal strain of more than -5, that means going down, so 5, 3, 4, etc., is associated with pure transmural scar, is what we have looked at a lot of patients. If we accept that -5 or less, now it's stated here more because it's more positive, but let's say 5, 3, 4, etc., if we accept that as a marker of scar, we can, in a polar plot of the ventricle, indicate where the core scar is in a patient, as shown here in the middle. You see that the bluish are the, in the middle, are the infarct core, and then you see that this area around here in green is the peri-infarct zone. And then this area around here, the more reddish, the normal area, is the normal area. So we're doing exactly the same as the MRI. We're just looking at the core zone, then the infarct pure scar, then secondary looking at the peri-infarct zone, and then the normal zone. So I skip a few here. And I show you this last trial that we have done. We looked at 424 heart failure patients, 88% men, 61.6 had combined ICD with CRT. The median follow-up duration was 24 plus or minus 24.2 months. 84 patients died during the follow-up, and 22% experienced appropriate ICD therapy. And the median time to ICD therapy was 10.5 months. So we looked at the predictors for the primary endpoint, mortality, secondary endpoint, the shocks. And you see that the primary endpoint, the diabetes, is strong, as we would expect. The kidney function, which shows how bad the heart is functioning. The New York class, how bad one feels. But also this peri-infarct systolic strain gives us some information. The secondary endpoint for shocks, the peri-infarct systolic strain is a strong predictor. If we then here see the Kaplan-Meier curves and we split them according to the mean, then you see that the peri-infarct strain, when it goes more from, let's say, in the direction of preserved, so from 9, 10, 12, etc., so there's more preserved strain, then the mortality is less, indicating that we have a core infarct where the strain is down. We have an area around that where the strain is in the middle, and we have a complete remote area where the strain is normal. And the larger this area in the middle is, the more predictive it is of mortality. Here you see the same for appropriate ICD shocks. And based on what I have shown to you, I think the sudden cardiac death is a problem. On the one hand, we have the patients with a low EF, where we probably implant too many ICDs. On the other hand, we have the patients with a preserved EF, where we don't implant many ICDs at all. So if we could better target the patients that would benefit from an ICD, it would be a big step forward. Primary prevention ICDs, as I showed to you also from the MEDA trial itself, do not shock up to 65%. Probably in the future, if we could better image the myocardial substrate, we could better risk stratify. Again, associated with sudden death is the scar and thus the ejection fraction. The ejection fraction is not ideal. We probably in the future move towards this strain assessment. But also we have this ischemic border zone. This border zone between the pure scar and the remote area. And that is probably another key to be a good predictor. Nuclear is looking at viable but denervated. On MRI we look at this intermediate contrast enhanced zone. And on echo, we can do the same with the reduction in strain. So I showed you this transition from pure scar, then you have the intermediate area, and then you have the remote area. And the bigger these areas are, the more instability there probably is. Thank you very much for your attention.
Written here is gratitude and appreciation.